So, and as Alain was saying, I will try to convince you that spontaneous breathing is in fact dangerous, can be in fact dangerous, but just keep breathing for time being, and then at the end of the talk we will decide. So these are my conflicts of interest, which are not really related to this presentation. And of course, I am also convinced, and I always show this slide when I give a talk on this topic, I'm also convinced that indeed spontaneous breathing has a bright side. There are many advantages of letting our patients spontaneously breathing, and today we have Alain, who is on the bright side of the moon, that just presented all these good aspects. But at the same time, I think it's important to keep in mind that there is a dark side of spontaneous breathing, and that this dark side can be very dark. Although, as I was just reminded, it's always darkest before the dawn. So for some of our patients, maybe going through a very dark time means that then they will end up on the bright side of the moon. So if we take a look a little bit at the recent, let's say, larger studies published on this topic, we have this quite famous study from France, and of course I've tried to find Alain's name among the authors, but I couldn't. And so this study was, I think, a very interesting and well-done study by the group of Laurent Papazian, and I'm sure you are quite familiar with these results. They randomized patients with a PF ratio lower than 150 to receive either cisatracurium or placebo, and then open-label cisatracurium was allowed in both arms. And they found a quite remarkable difference in the survival between the two groups, and I don't have the slide here, but this difference was more pronounced, was actually due to the more severe patients with a PF lower than 120, I think. One thing I like about this study also is that, you know, patients were not just left on neuromuscular blocking agents for a week and forget it. There were an early phase of, let's say, aggressive paralysis, if I may use this word, but then weaning attempt was started. And so there was a kind of separation of the two phases, a very controlled phase, and then a more spontaneous breathing phase. So if you look at this slide, of course, you could conclude that I am, in fact, rightly claiming that spontaneous breathing is dangerous, because if you block it, patients survive more. And then, of course, this study was a little bit controversial. Not everything was clear. The mechanisms were not that clear. So the PETAL network, how it is now called, what we have always known as the ARDS network, basically did the study again with some differences. The greatest one, going back to Alain's point, was that in these let's say, more recent study, patients were managed with higher levels of PEEP than in Papazian's study. But to make a long story short, they found no difference between patients in whom neuromuscular blocking agents were used as opposed to patients in whom there was less use of neuromuscular blocking agents and less sedation. It's interesting, however, just not to stop at the Kaplan-Meier, but look deeper at the results. And I think the authors are very clear in their discussion. It's a very well-written paper, because the discussion is very honest and very clear. And something that they point out is that also in the control group, there is a number of patients, 15 patients, in whom, despite being randomized to not having neuromuscular blocking agents in place, still the clinicians decided to violate the protocol and give them neuromuscular blocking agents. And interestingly, this percentage is higher at 96 hours than in the intervention group in whom neuromuscular blocking agents were used from the beginning. So the dark blue bars are patients who should not receive by protocol neuromuscular blocking agents, but still were given neuromuscular blocking agents. And also, it's quite interesting to take a look at the flow chart, because of course we have 655 patients who were excluded from the study because they were already receiving neuromuscular blocking agents, and as my mentor Antonio Pesenti always says, these patients are excluded from the study because their clinician decided to start neuromuscular blocking agents. So it was likely indicated in them, because there could be a pick the winner strategy. So I think that this study supports the fact that the evidence that, let's say, unselected patients population should not receive neuromuscular blocking agents, but still it doesn't rule out the role of neuromuscular paralysis during severe ARDS. So what are the mechanisms by which spontaneous breathing can and is injurious? What is on the dark side of the moon? Alain briefly mentioned this. One topic which is, I think, often neglected, and I found out about this because of a study we done I wasn't expecting, is the fact that by breathing we can increase the oxygen, our patients can increase their oxygen consumption in a non-negligible way. So if you take a look, if you take a read at the book of physiology, it will tell you that now you're using about 5% of your VO2, of your oxygen consumption, in order to breathe and to move your lungs. But if you take a look at these patients, these are patients in a weaning conditions in whom the level of assistance, pressure support, was decreased from a given level down progressively. And as you see, the amount of oxygen that they use can be 30–40% of the total oxygen consumption of the body. So when we are posing an excessive workload on the muscles of our patients, just because he or she is breathing, it's like we are posing our patient on a treadmill. And think about a patient who is already hypoxemic, we might be at risk of increasing oxygen consumption by 30–40%. But then there is another, and I think more compelling argument, and maybe we can discuss this along with Alain's study later on in the debate, which is the pay that we price to the freedom we are giving to our patient, okay? The patient is free or more free to generate high tidal volume and non-protective tidal volume. And so, for example, if we, of course, I must have at least one lung-safe slide. If we take a look at the tidal volumes in patients who were on spontaneous modes in the lung-safe cohort, these were higher than the fully controlled population. But as a paradigm for spontaneous breathing, I would use just for a few minutes the topic of non-invasive ventilation. Because to me, non-invasive ventilation is a sort of paradigm of what spontaneous breathing can do to the lungs of our patients, to the heart of our patients, and so forth. I think what really matters between invasive and non-invasive ventilation is not the tube itself, is once again the freedom that the patient has. And this is, just to give you, so this is the PCO2 of patients managed with invasive ventilation. And as you would expect, the more severe the patient is, the higher the PCO2, higher dead space, more difficult to ventilate patients, so it's not a big surprise. But if you take a look at PCO2 in non-invasive ventilation, it's exactly the other way around. The more severe the patient is, the lower is the PCO2. Because the patient did not go to any conference where he was told about patient self-inflicted lung injury. The patient knows that she or he wants to survive and that she or he is hypoxemic and the lung is stiff. And so breathes as much as possible, dropping down the PCO2. And this does not come for free. There is a price to pay that the patient has to pay to keep the PCO2 low. And the price the patient has to pay is a very high minute ventilation. This is a paper, very interesting paper published by Guillaume Carteau, who showed that the higher the tidal volume during non-invasive ventilation, the higher was the risk of NIV failure. So just keep in mind this information because we will get back to this in a minute. I'll skip through this for the sake of time. And then, of course, along with tidal volumes comes the other aspect, which is the high inspiratory pressure. And at least the tidal volume, we see it on the screen, we measure it, okay? But once again, nothing comes for free, and tidal volume doesn't come for free either. There is a pressure that the patient needs to generate to get the tidal volume in. And the pressure are not always seen on the ventilator screen. Sometimes the pressure are hidden, exactly like an iceberg. We see the part of the iceberg, the part of the pressure which is on the ventilator screen, but we do not see everything which is inside the patient, which is hidden below the water. And so it would be, this pro-con debate probably would never have happened if in all patients we would have an esophageal pressure in place, because there we really would know the total pressure applied to the respiratory system. Because the point is, we do not know what is inspiratory pressure in a patient who is spontaneously breathing. This is not APRV, this is pressure support. I'm sure that we frequently manage spontaneously breathing patients with pressure support. And this is a question I have for you is, what is the inspiratory pressure? Is it what we see on the ventilator screen? Do we have a lower total inspiratory pressure on your left-hand side just because the pressure we see on the ventilator is lower, do we have a higher pressure on the left just because the peak pressure we see on the vent is higher? Is that so simple? I don't think so. If we go back to the Carteau paper which I showed you, again, this is non-invasive ventilation, but the concept is the very same. Just take a look at these patients in the NIV failure group. They had a PEEP of 5 and a pressure support of 7.5. So peak inspiratory pressure was 13 centimeters of water. How many of us would be concerned by a peak inspiratory pressure of 13 centimeters of water? I don't think anybody would be. But these patients were subsequently intubated. And we know that the tidal volume they generate was 742. So because of some calculations, you can do this in the paper, okay. And after they were intubated, it turned out that their compliance was 27 ml per centimeters of water. And to make a long story short, to generate a tidal volume of 742 ml with a compliance of 27, you need a driving pressure of 27 centimeters of water, which with a PEEP of 5 equals a plateau pressure of 32. Now, you see on the screen of the ventilator 13 peak inspiratory pressure, but the real driving pressure is 27. How many of you would be concerned? Everybody would, I guess. And we also reinforce this concept by publishing a paper with a quite obvious result, if you wish. So a reviewer said, this is quite obvious, another said, this paper doesn't make sense, but at the end of the day, we managed to publish it. But basically, we reanalyzed some data which we had from patients moving from fully controlled mechanical ventilation to high, medium, and low level of support. Again, this is pressure support, but it would work out for APRV as well. And we saw that although the pressure on the ventilator screen got lower, the total pressure across the system was exactly the same. We had the same transpulmonary pressure no matter who was generating the pressure, whether it was the patient or the ventilator. And so, if I ask you the question again, what is the real pressure across the respiratory system, I think we are nowadays learning that, in fact, we can use the inspiratory hold method also during assisted ventilation, and if we push the inspiratory hold button, at some point we will see that the patient relaxes the muscles and the pressure comes back into the system. So, in fact, we read a plateau pressure, which is a real plateau pressure, which is exactly the same. It doesn't matter if the breath is more controlled or is more active, but we have to check for it because sometimes this pressure can be very, very high. And so we thought, well, if this driving pressure has the same meaning as during controlled ventilation, it must have the same association with outcome. And we published a paper on anesthesiology showing that the peak inspiratory pressure you see on the ventilator during assisted ventilation, during spontaneous breathing, has very little or no association with outcome. But in fact, the driving pressure that you do measure by this method has an association with outcome. So I agree with Alain, it's very important to monitor the tidal volume that the patient spontaneously generates, but we need to have an idea of what pressure corresponds to that tidal volume, because 400 ml tidal volume can lead to very different inspiratory pressures, and it's a little bit tricky during assisted ventilation. Alain told you that the spontaneous breathing is good for hemodynamics, and on one hand I agree with him. On the other hand, we have to keep in mind that this negative pressure that the patient generates is increasing the afterload for the left ventricle, because the left ventricle will have to generate a pressure which is equal to the systolic pressure, which is, let's say, 100, but if it is surrounded by a negative environment, by the pressure which the patient generates with her or his muscles, this will cause an increase in transmural pressure for the left ventricle, hence causing an increase in the preload in the afterload of the left ventricle, and this is the reason why non-invasive ventilation works so well in acute cardiogenic pulmonary edema. So it is true, there is some benefits on hemodynamics from spontaneous breathing, but although, as I say, the transpulmonary pressure is the same between spontaneous and controlled ventilation, those negative pressure swings that the patient generates are seen from the heart. And getting to the last point of my talk, Alain, of course, highlighted the benefits of asynchronous, because asynchronous limits the risk of breath stacking and increased tidal volume during spontaneous breathing effort. At the same time, there are studies in the literature showing an association between increased asynchronous and worst outcome. And again, I have to be honest, all these studies are like a little bit of the egg and the chicken question. We don't know whether the most severe patients have more asynchronous or die more, or the other way around, that asynchronous are somehow causing lung injury, diaphragmatic injury, and so they are contributing to an increased risk of death. But the evidence is there. There is definitely an association between asynchronous and worse clinical outcome, and this is just a one of the examples. I think it's also important to keep in mind that when asynchronies are at place, the diaphragm can generate very intense efforts, which are also iso or plyometric. So when the patient is exhaling, the diaphragm contracts, so the movement and the force are in the opposite generation. And the same group who, of course, is leading the research on that topic has shown that, yes, if you have no effort at all, the duration of mechanical, if the patient has no effort at all, the duration of mechanical ventilation is increased, but also if the effort is too high, there is a risk for prolonged mechanical ventilation. And as a last slide, I would also recall that we are learning that Pendelluft can occur within the lungs. So spontaneous breathing promotes asynchronous not just between the patient and the ventilator, but also within different lung regions, because air can move within the lung from a region to another. This could cause lung injury, but we are also testing the hypothesis that when the patient is spontaneously breathing, and the more the patient spontaneously breathes, the more this workload generates Pendelluft, and CO2 moves between the different parts of the lungs, causing ventilator inefficiency and increasing further the respiratory workload, hence causing a vicious cycle. So these are my conclusions. Patients do not always know what is best for them. Okay, I think we have to accept this. And the inspiratory muscles can generate huge pressures we will never tolerate on the ventilator screen. And these can cause a possible injury on lung, heart, and diaphragm. And so, ladies and gentlemen, just reminding you that you don't want to get into a fight with an Italian, I have to ask the question for you. No, just kidding. Please be honest, because it's very interesting. So, did this debate change your opinion? Yes, now you are in favor of Elan, or no, you were in favor of Elan before and it didn't change your mind? Or yes, you are now in favor of the con speaker, so you change your mind and you are now in favor of myself, or you were in favor with myself and this didn't change your mind? The question is not, it's a bit tricky to understand, but ESICM told us just to show this slide, and we did. So, vote. Start the vote.
So you can vote now.
Alain, you cannot vote. Why don't you...
Okay, very. Alain, do you want to come here? Yeah. Okay, so it seems that majority of the people is in favor of the con speaker, meaning that majority of you think that maintaining spontaneous breathing during acute respiratory failure is dangerous. So do you have any questions or comments about what was said by Alain and Giacomo?
I'm very surprised because I see that everybody has spontaneous breathing activity. You should assume and stop to breathe.
Good morning. Thank you very much for the discussion and the presentation. I would like to ask you a question regarding not really mechanical ventilation, but how do you explain the positive effect of high flow oxygen, which showed that in the most severe patient, high flow had a positive effect, and those people are spontaneously breathing?
Yeah.
So how do you explain this in the context of...
So, thank you very much. And of course, you know, we were just chatting with Alain, and when you do this pro-con debate, if you say more or less the same things, it's not fun. So you have to stand a bit on let's say extreme position, and I'm positive that also Alain sometimes uses neuromuscular blocking agents in his patients. So of course, I think that there is definitely a role for spontaneous breathing. I just wanted to highlight the potential dangers. So getting to your question, as Alain said, we are all spontaneous breathing. To a certain point, this can be tolerated, and in fact is probably better than intubating the patient. And if we can decrease the work of breathing with high flow nasal cannula and increase a little bit the end expiratory lung volume, that is probably why high flow nasal cannula works. So in fact, I think that one of the reasons high flow nasal cannula works so well is because by decreasing the dead space, washing out CO2, it has been shown by several investigators that the work of breathing is decreased. So we keep the patient spontaneously breathing, yes, but we make spontaneous breathing less dangerous. And I think this is the point, okay? We need to be aware that there is a danger coming from spontaneous breathing, and we have to try and monitor this. And we have to find ways, and as you mentioned, high flow nasal cannula is one of these, to reduce the impact of let's say, of negative pressures generated by the patient. So this would be my answer.
Other questions, comments? Maybe one there. Then I have a question for Alain.
Yes, good morning. Thank you for the presentations. And what do you think about the partial curarization to maintain spontaneous breathing and control of respiratory efforts?
Yes, partial neuromuscular.
Partial curarization.
Yes, it is. Yes, it is a new strategy. It is interesting. In fact, it is a pharmacological induced diaphragmatic weakness. It is we have very few data, very interesting. The idea is that in patients with acute respiratory distress syndrome, in most of them, the level of dry is very high, especially at the acute phase. For several reasons, and some reasons are not so clear, it is very, very high. So the drive is high, so if you allow the patient to breathe, you will make very strong efforts. My first point is, to be clear, I am sure that spontaneous breathing has many advantages in this patient, but I am sure that it is not possible in every patient every time, especially at the early phase for the most severe patient, because it is impossible to control the drive. Even with large doses of sedative, for example, morphine is, you know that morphine is very efficient to control the drive in a healthy subjects. Anesthesiologists know this very well. But in patients with ARDS, it doesn't work. Propofol may be a little bit better than midazolam, but in some patients, the most severe one, you cannot control. So the idea is to give small doses of neuromuscular blocking agent. You do not control the drive. The drive is still high, but you decrease the efficiency of the respiratory muscle. It is a strategy that is proposed. It is until now we have some physiological data, but not clinical data showing that it is possible to use this strategy. I would add another comment to many of the slides shown by Giacomo were slides showing the screen of a ventilator. All of you have the modern ventilator with this very nice screen. And my message is look at the screen. You will see many things. In the passive patient for passive respiratory mechanics, and in the actively breathing patient. You will recognize asynchronies. You can, by performing occlusion, You can try to measure the true transpulmonary pressure, inspiratory transpulmonary pressure. And I would add another point, is that in all modern ventilators now, you can easily obtain a parameter that his name is PO1. PO1 is the pressure 100 milliseconds after the beginning of a breath against an occlusion. It has been shown to be an index of respiratory drive. And in patients in the ICU, mechanically ventilated patients, there is a very good correlation between PO1 and the level of the intensity of respiratory effort. So, for example, if you have a patient on partial ventilatory support, you just check, you have to push on a button. Even on some ventilators, you have to push on nothing. It is continuously on the screen. And if you see a PO1 of, let's say, 7, 8, 9 centimeters of water, this patient is making very strong effort. Okay, it is very easy. It is on the screen of the ventilator. You have just to look at the screen. Of course, the best way to check the level, the intensity of inspiratory effort is the use of esophageal pressure. We have now some very simple to use nasogastric tube with a balloon. It can be connected on an auxiliary pressure transducer on the ventilator. You can have this on the screen, and it is very meaningful for assessing the level of effort, the synchrony. I think it is a strong message now. Use the capabilities of your machine to try to understand what the patient is doing. Giacomo?
No, I just wanted to ask, if there's time, to ask you, if you have the PO.1 in the birds measured?
No.
That was my question.
And what, like, if you would make it practical, you mentioned, for example, 9, to make it practical, what, if one wants to implement your strategy, what would you target for PO.1?
Yeah.
Just to
I think a PO1 lower than 4.
Make sense.
It's okay. It's okay for me. Between let's say 4 to 6, there is a question. If there is the ventilator tend to underestimate a little bit, so it means that the patient, at least if you are at 4 or 5 or 6, the patient is making very strong efforts.
Couldn't agree more on the PO.1.
Okay, so we have to close this session. So thank you all for being here. Thanks to the speaker.